So anti-helminthics is an important chapter in our pharmacology that deals with the helminths. The helminths actually they are worms which are macroscopic multicellular organisms having their own digestive, excretory, reproductive and nervous systems. So basically we have drugs that will expel or kill these microorganisms, macroorganisms in our body and cause the expulsion. So we need to know the drugs that act. So the most important and the fundamental drug that have been used time and again is albendazole. Now we have certain classification of drugs, but the classification varies from one book to another. So it's not about the classification, it's about the drug that you need to remember. So starting with albendazole, uh, the first important point that you have to keep in mind that it is a broad spectrum antibiotic, broad spectrum anti-helminthic. Right? That is the most important thing. That it means that it can be used against nematodes, it can be used against trematodes, it can be used against the cestoda also. Cestodes as in your tapeworms. So it is a broad spectrum oral anti-helminthic, both in a solution form and as an oral tablet, belonging to the benzimidazoles group. This is one of the important groups that we have, and it includes other drugs also, such as mebendazole. So we call these both are cousins in the family, albendazole and mebendazole. And then we have got thiabendazole. It has got a sulfate group in this, and hence it is thia. And then we have got triclabendazole. So in your exams, either albendazole is asked or mebendazole is asked. So in this particular chapter, we'll be learning about in detail about albendazole. So albendazole is a broad spectrum anti-helminthic of the benzimidazoles group. Now, how does it function? Now, to understand that, you need to first look at the cytoskeletal structure of an anti-helminth, of a helminth parasite. It actually comprises of three important forms, three important structures. The first is your microfilaments. The second is your microtubules, and the third is your beta tubulins. Microfilaments, microtubules, and your beta tubulins. Now we are going to talk about only the microtubules over here and the beta tubulins, because this is the site of action where all the story happens or the story unfolds. So what happens is, if you imagine this to be your this to be the microtubule of a parasite, right? Now at the end of the microtubules, we have got a dimer of beta tubulin. Let me use another color pen. We have got a dimer of beta tubulin. Now this beta tubulin, as it moves along the microtubule, it undergoes polymerization. This is a dimer, but as it proceeds to on the microtubules, it undergoes the process of polymerization. And when it undergoes polymerization, it helps in activating or it helps in renovating the features of microtubule, so that it helps in certain aspects of the helminth. So as it proceeds, it undergoes polymerization, and when the process of polymerization is done, it again becomes a dimer over here. Now what happens is, when you give albendazole, it goes and attaches itself over here. It goes and attaches itself to the dimer, which is your beta tubulin. And when it goes and attaches, it doesn't allow this particular beta tubulin to go over the microtubules. And when that does not happen, the polymerization process doesn't occur. So if you read the text over here, you will find that the formation of microtubules is dependent on the polymerization of beta tubulins. Albendazole binds to the beta tubulins and prevents their assembly. It prevents their assembly. So polymerization is synonymous with assembly of microtubules. So when that does not happen, it results in the breakdown of cytoplasmic microtubules. It results in the breakdown. So that is the reason why, that is how albendazole acts, has the mechanism of action, and it destroys the cytoskeletal structure of the parasite, right? So you need to remember microtubules and you need to remember the beta tubulins. All right. Albendazole goes and binds to the beta tubulins, and when it does that, it prevents the polymerization. And when polymerization doesn't happen, the assembly of microtubules doesn't happen, and the cytoskeletal structure of the parasite fails to form. Right. Now, after having learned the mechanism of action, let us go to the pharmacokinetics. Now, the pharmacokinetics is quite variable. That means if you take it without food, it might not get absorbed rapidly. But if you take it with a fatty meal, remember fatty meal, it will increase its absorption. It is rapidly metabolized in the liver, like majority of the drugs that we have, to an active sulfoxide metabolite. Right. So these 3 points you have to remember with respect to albendazole. Its absorption is quite variable. You need to have fatty food, fatty as in any stuff, right? And it is rapidly metabolized in the liver to an active sulfoxide metabolite. So just remember this sulfoxide metabolite. Now moving on, albendazole has got a plethora of clinical uses. It is used against intestinal nematodes, it is used against cystodes, it is used against the liver flukes also, which belong to the family of trematodes. Right. Recall your zoology in your second intermediate, and this is what we are learning since you have not yet gone into the microbiology part of it. So it is used against all the majority of the parasites that we have. Now, apart from that, it is actually a drug of choice for nematodes such as Ascaris, the common roundworm, and then you have got Trichuris trichura, and then Ankylostoma duodenales and Necator americanus. So these are the 4 parasites against which albendazole is a drug of choice. Trichuris trichura is actually whipworm, and both of them are hookworms. Now, when an adult of let's say more than 2 years of age, or children above 2 years in age, when they are infected with these parasites, what is the dose that you need to give? Because in this chapter, the dosage and the dose are very important. So you have to remember certain dose and dosages. So for adults and children above 2 years suffering from these parasitic infestations, you have to give a dose of albendazole in 400 milligrams orally 1 HS. That means at night. This is for adults and children above 2 years. Now, what if a child between the age group of 1 and 2 is infested with these parasites, and it is actually a common occurrence? So what will be the dose? The dose will be half of it, that is 200 milligrams OD. Now, if you have done studies, if you have done some lab works, and you come to know that there is a heavy infestation of these parasites in a patient's body, so you need to continue this therapy for about 3 days. So this is about these drugs and the doses of it. Now, the albendazole is also used for the treatment of strongyloid stercoralis, and it is also used for the pinworm, Enterobius vermicularis. Right. So, what is the dose for it? The dose is the same, which is 400 milligrams OD. 400 milligram OD into 3 days. Now, there are other anti-helminthics also, and which are used along with albendazole to provide a synergistic combination to fight against more dreaded worms, and those are your filarial worms. So, in a case of lymphatic filariasis, albendazole is given in combination with diethylcarbamazine or ivermectin. These are the drugs that we are going to study in the later slides. So, first is it is used in the intestinal and nematodes and cestos as well as trematodes. It is drug of choice for these four parasites, and then it is used in strongyloids and enterobius infestations. Plus, for heavy infestations such as lymphatic filariasis, it is used in combination with D or I. Now, look at the fifth point over here. This is actually a 4 marker for you in microbiology. It is also a preferred drug to treat cutaneous larva migrans and visceral larva migrans. Right. Now, the dose will be 400 milligram OD into 5 days for cutaneous larva migrans, while for the visceral, it will be quite extensive, 400 milligrams OD into 28 days. Now, coming to the tapeworms over here, it is a drug of choice for cysticercosis and hydatid disease. It is used in a dose of 400 milligram BD into 28 days. Now, so these are some of the clinical uses of albendazole, which are the most primary, which are of prime importance. And the things that you need to remember is the drug of choice. It is a drug of choice for these four worms, and it's also a drug of choice for cysticercosis and hydatid disease. So the dose that is quite common in all these is 400 milligrams. So it is quite easy to remember. So just remember the days and the timeline that you have to give this drug. Moving on to the adverse effects. Adverse effects or toxicities appear only when you have taken albendazole for more than 3 months together. Right. So it usually causes epigastric distress, it causes headache, alopecia, it causes fatigue and insomnia. So these are the 5 relevant adverse effects that appear in an individual who has taken albendazole for more than 3 months. Right. Epigastric distress, GIT, CNS, fatigue and insomnia. So this is all about albendazole. Moving on to the next important drug, we have got diethylcarbamazine. Now diethylcarbamazine is actually a piperazine derivative. It is synthetic. Now, the mechanism of action of diethylcarbamazine is quite extensive. And what you need to remember from this is that apart from albendazole, this drug is also quite commonly used. And before we know where it is used, what are the clinical uses of it, we need to first look at the mechanism of action. So what it does is it basically acts on the, if you imagine this to be a parasite, it basically acts on the surface of the parasites. And when it acts on the surface of the parasites, what it does is it alters the membrane surface. And when it alters the membrane surface, certain modifications are done on this surface that exposes it to the immune system of the body, and subsequently phagocytosis of the parasite is by the monocytes. The second mechanism of action is that it hyperpolarizes the worm's musculature. When it hyperpolarizes, that means the worms which is now clinging onto the abdominal wall or any other wall in the human body, what happens is uh, the clinging action of parasites is dependent on calcium. And when you hyperpolarize a cell, that means you are removing the positivity from the cell. And positivity, once it goes, that means the cell gets hyperpolarized. That means calcium isn't there and the contraction process doesn't happen. And when the contraction process doesn't happen, the, the, the parasite will lose its grip on the intestinal abdominal wall or wherever it was lodged, and it will be expelled out. So that is the second mechanism of action. Third is it also causes the local production of prostaglandins, resulting in capillary vasoconstriction. And when capillary vasoconstriction happens, there will be impairment of the passage of microfilaria. And when they are impaired and they're stuck in one location, they ultimately die. And then they are expelled from the body. So these are the three mechanisms of actions for diethylcarbamazine. First is it alters the membrane surface. Second is through hyperpolarization. And third is through prostaglandins. Coming to the pharmacokinetics, it's quite rapidly absorbed from the GIT. It is widely distributed and it is excreted unchanged in urine. Now, one problem with diethylcarbamazine is they cannot be given in patients having renal pathologies. So whenever you have a patient who is in dialysis or who has got nephrotic syndrome, nephritic syndrome, or any other renal pathology or any other acute kidney injury, you have to adjust the dose while giving diethylcarbamazine. So that is the one point that you have to remember with respect to diethylcarbamazine. Looking at the clinical uses, it is used in the treatment of, it is actually a drug of choice for the treatment of lymphatic filariasis. Right. Now, it is also used in the chemoprophylaxis of loiasis and filariasis. And what these three things have in common is the regimen. Regimen is a 3-day regimen, and on the first day, you have to give 50 milligrams. On the second day, you have to give 50 milligrams TDS. On the third day, you have to give 100 milligrams TDS or TID. Then after the 3-day regimen is done, you have to continue with 2 milligram per kg body weight 3 times a day for 2 to 3 weeks. So if a patient, let's say, is 70 kgs, that means you have to give this drug 140 milligrams 3 times a day for 2 to 3 weeks. Okay. Then it is also used for tropical eosinophilia. It is used again in tropical eosinophilia, and it is given in a dose of again 2 milligram per kg 3 times a day for 7 days. Now moving on to the adverse effects, this is 2 milligram per kg TID into 7 days. Now moving on to the adverse effects, there are two types actually, and we have got pharmacological dose dependent adverse effects and also allergic reactions. So the pharmacological dose dependent is as you go on increasing the dosage or you go on extending the therapy of diethylcarbamazine, the patient is bound to have one or all of these side effects. So it starts with headache, weakness, general malaise, then there will be your classic nausea and vomiting, dizziness and lethargy. The patient also complains of anorexia. Now, the allergic reactions includes fever, edema, rashes, and cutaneous swelling. So these are the 4 important allergic reactions that you will find in common with other antihelminthics also. So remember that for diethylcarbamazine, we have got 3 mechanisms of actions that is quite unique, and then it has to be adjusted in cases of renal impairment, and then about the adverse effects, right? So this is about diethylcarbamazine. Moving on to the next, we have got ivermectin. Ivermectin is actually a mixture of 2 compounds. It is called avermectin B1A and B1B. It is a semi-synthetic macrolytic lactone, and it is derived from Streptomyces avermicillus, hence the name ivermectin. Right? So this is about a brief introduction of ivermectin. Now moving on to the mechanism of action. What it does basically is it attacks primarily the glutamate gated chloride ion channels in the nematodes, because it is actually very characteristically against the nematodes, acts against the nematodes. Now, when the chloride ion channels, the glutamate gated chloride ion channels are attacked or activated, they cause inhibition due to subsequent hyperpolarization. So when they are opened, chloride drives in, and when chloride drives in, the cell gets hyperpolarized. And when hyperpolarization occurs, there will be flaccid paralysis, and when flaccid paralysis occurs, there will be expulsions of the paralyzed worms, because the worms are not able to attach themselves on the intestinal abdominal wall, and when they can't attach themselves, they'll be flushed out of the body. Right? It's quite a simple mechanism of action. It acts on the glutamate gated chloride ion channels, and when chloride drives in, it causes hyperpolarization, leading to flaccid paralysis and expulsion of the paralyzed worms. The pharmacokinetics, it's quite simple. It is absorbed from the GIT. There is wide distribution of this particular drug and excreted in the feces. Now, coming to the clinical uses, it is a drug of choice for onchocerciasis. Now, for this particular disease, it's quite important that we have to continue the regimen for it, or the treatment for it, for 6 months. Right. Now, when you continue this regimen for 6 months, you have to make sure that the age of this particular patient is more than 5 years. So that is the first prerequisite for giving ivermectin in a case of onchocerciasis in a patient. Right. The second thing is, you have to give this particular drug in a dose of 150 milligram per kg. Right. So that is the second thing. And for adjunct therapy, you have to combine it with corticosteroids. So you give it every 6 months. That is the first prerequisite. You give it for individuals more than 5 years. The second prerequisite is it is given in a dose of 150 milligrams per kg, and it is given along with corticosteroids. Now, apart from the action on onchocerciasis, ivermectin is also used for the treatment of lymphatic filariasis and loiasis. Right. Now, what happens in this particular case of lymphatic filariasis is, when you begin the treatment, it will actually reduce the microfilarial larval load. But it does nothing to the adult ones. So it is a good drug for lymphatic filariasis, mostly the larval forms. Then it is also used in a disease called as disseminated strongyloidosis, and it is given in a dose of 200 microgram per kg for 2 days, and it is given orally. So these are quite important diseases that you have to study about. Then again, it is also used in cutaneous larva migrans, the ones we have studied before, and it is also used in the effective treatment of pediculosis, that which is lice infestation and scabies. The dose will be the same, which is 200 microgram per kg, single oral dose. Now, let me tell you some important points about onchocerciasis. What happens in that is, as I've already told you, corticosteroids have to be used, and they have to be used actually to avoid inflammatory eye reactions. Now, annual treatment can prevent blindness from ocular onchocerciasis, and in lymphatic cerciasis, it reduces the microfilarial load to nearly zero level, but does not kill the adult forms. In cases of loiasis, uh, it does reduce the microfilarial load, but its potential to produce neurotoxicity in these patients discourages its use. So, since it is actually a neurotoxic on high doses or on prolonged treatment, in case of loiasis, it is actually discouraged. But for others, you can give it. Cutaneous larva migrans and treatment of pediculosis and scabies, it is given in a dose of 200 mcg per kg, single oral dose. Now coming to the adverse effects, it's fever and pruritus along with hypotension and tachycardia. Now you have got hypotension and you have got tachycardia. So if you go back to your ANS concepts, you will know that whenever there is a sudden drop in BP, the baroreceptor reflex loop comes into picture. And when then it comes into picture, it tries to revert back to its original state and causes tachycardia. So let me write over here, it is actually a reflex tachycardia, and that can induce arrhythmias if not controlled. So this is all about ivermectin. So we are done with albendazole, diethylcarbamazine, and ivermectin. Now coming to the last drug on this particular topic, that is your praziquantel. Praziquantel is a synthetic drug and a derivative of isoquinoline and pyrazine. Right, praziquantel. Now, what is the mechanism of action? Mechanism of action is that it causes influx of calcium from the endogenous stores of the cestodes, resulting in intense contractions. So it causes or releases multi-loads of calcium from the stores of the cestodes within the body, and it induces contractions. And when contractions occur, it results in expulsion of the worms from the gastrointestinal tract. Now, one more thing which this calcium does is, the influx of calcium does is, it causes the damage to the tegument in case of trematode flukes, and that produces vacuolations or holes on the tegument of the flukes. And when that happens, the antigens of the parasite gets exposed, which are later destroyed through phagocytosis. So basically, calcium is doing two things. First is there will be influx of calcium within the body of the parasite, and that will cause tremendous contractions. And when there are tremendous contractions, the worm loses its grip on the intestinal abdominal wall and it is expulsed out. Now, the other thing what calcium does is, it also, if you imagine this to be your parasite, it causes vacuole formation. And when vacuole formations are done, the antigens they are exposed to the immune system of the host body, and they can cause phagocytosis. So that is how praziquantel works. The pharmacokinetics, it's quite simple. It is readily absorbed orally, and it has got significant first pass metabolism in the liver. Moving on to the clinical uses, it is used as a drug of choice for schistosomiasis. It is used as a drug of choice for schistosomiasis, and it is given in a dose of 20 milligram. It is given in a dose of 20 milligram per kg orally BD. So it is a drug of choice for schistosomiasis, and actually we have got four types of parasites that belong to this family, and first is Schistosomia mansoni and Schistosomia hematobium. So for that infestation, we have to give this drug in a dose of 20 milligram per kg orally BD. While for Schistosomia japonicum and McCongie, 20 milligram per kg orally, but it will be 3 times a day. That is for schistosomiasis, and it is a drug of choice. Now, in cases of tapeworm infestations, the same drug can be used, and it is given in a dose of 10 milligram per kg, and it is a single dose. Then comes the most infamous neurocysticercosis. Now, for the treatment of neurocysticercosis, you have to give this drug in 3 divided doses. Let me write 3 over here. 50 milligrams per kg daily in 3 divided doses. In 3 divided doses for 15 days, and that kills the larva lodged in the brain. Okay. Apart from that, one thing or one point that you have to remember with regards to praziquantel is that corticosteroids reduces the bioavailability of praziquantel, and hence corticosteroids cannot be given in patients who are receiving praziquantel. And other thing that you have to remember for praziquantel is that it has to be avoided in pregnancy. Now, coming to the adverse effects, if you look at, we have first got the CNS effects, and that is headache, dizziness, and drowsiness. That is the first adverse effects that is commonly seen with praziquantel. And then we have got the GIT manifestations, which are nausea, vomiting, and abdominal pain. And if you come to the dermatological side effects, you will find that the patient suffers from pruritus, urticaria, skin rashes with eosinophilia. So these are quite simple. If you go systemic wise, and we have got headache, dizziness, and drowsiness for CNS, nausea, vomiting, and abdominal pain for GIT, and for dermatological adverse effects, we have got pruritus, urticaria, skin rashes with eosinophilia. Now, the last point over here that I would like to mention here is that there is contraindication of praziquantel in ocular cysticercosis, because what happens is, because of the risk of severe eye damage, actually when we use praziquantel in ocular cysticercosis, the drug kills the larvae. But what happens is the larvae get die in the ocular area, and they cause occlusion due to the dead parasites. And when that happens, there will be severe eye damage due to the antigens being released and all the immune reactions happening. So in cases of ocular cysticercosis, praziquantel, this drug is contraindicated.